I will talk about the pharmacological and psychological predictors of the MDMA response in a placebo-controlled study in healthy subjects. Right at the beginning, I have no potential conflict of interest to report. And this study was conducted at the clinical study site in the University Hospital in Basel by the psychopharmacology group of Matthias Liechti. You heard him on Thursday. And for this project particularly, there goes special thanks and also all questions and critics regarding the statistics goes to Erich Studerus and Samuel Harder. First, what is MDMA? Methylene, 3,4-methylene dioxy and methamphetamine. It is a stimulant, but it is also kind of the cover drug for a class called the entactogens. Entactogens are substances that invoke prosocial feelings and pathogenic feelings, actually. MDMA acts through the release and reuptake inhibition of serotonin, norepinephrine, and at least to a lesser extent dopamine. And it is as you probably know, the main component of the famous but yet illegal drug ecstasy, which is as such typically sold as pills or powders in a rave or nightclub environment. On the other side, MDMA is not only a recreational drug, but it is currently under investigation as a remedy for post-traumatic stress disorder disease, and with quite success. 6 phase 3 studies showed that 54.2% of the people who got MDMA did not meet PTSD criteria after only 2 sessions, compared to the control group, where the remission rate was at 22.6%. And after these remarkable results, 2 phase 3 trials with 200 patients are now on the way, and with the ultimate goal to make MDMA an FDA-approved medicine by 2021, which we heard is a quite ambitious goal, but I think it's fair to say that in the early 20s probably, if the phase 3 trials were successful, we can expect MDMA to become a medicine. The aforementioned mechanism of action, so the release of the neurotransmitters, serotonin, norepinephrine, and dopamine, lead to an autonomic response. Here we see the blood pressure over the time of 6 hours. In red, we see the condition MDMA with 125 milligrams, and in blue, the control condition placebo. This here you see within comparison in 162 subjects, and you see the systolic and the diastolic blood pressure. And on the bottom, you see the heart rate also going up, as well as the body temperature is rising. You may notice that 37.4 degrees Celsius is not a lot, but we had subjects that reached over 39 degrees. And you have to bear in mind, these subjects are lying in a bed and are completely or mostly relaxed, and not in a crowded dancing environment like in a nightclub, where the situations can get dangerous with these temperatures. Also here, to the subjective effect, of course, you can see on the first side, the subjects perceive the drug effects predominantly as positive, with only minimal bad drug effects. We are looking at data captured by a visual analog scale. So we heard that before. It is a like the subjects had to mark on a horizontal line if the statement, for example, good drug effect is true for them, not at all, or extreme. And the same goes for the bad drug effect. And also, as I told you before, MDMA is classified as a stimulant, so we can expect a stimulating effect. And I think this is the reason, combined with the fact that the drug effects are quite likable, that it is taken in a recreational setting to stay longer out at night, to dance. And also, as we see in the next slide, to interact with people. So it is an entactogen, and here we see the entactogen typical effects. Subjects became more open and had increased feelings in closeness and trust to others. And those effects ultimately result also in an increased need to talk, as not only the subjects can tell you, but also the investigators. I think those effects are I think most important for the MDMA's success in a psychotherapeutical setting. So next, the subjective effects wouldn't be covered enough if we wouldn't go through the 5-dimensional altered states of consciousness. And here we see very shortly, MDMA increases all items significantly compared to placebo. And most pronounced were the effects in the blissful state, with statements like, I experienced a profound peace in myself. And of course, the experience of unity, conflicts and contradictions seem to dissolve, and as well the changed meaning of precepts. So everyday things gained a special meaning. So we saw a lot of effects from MDMA, and of course those effects are not the same in all subjects. So we asked ourselves, is there a way that we can predict the effects for each subject? And we did this by defining the character, for example, or even the genetics and the sex, and of course the set, so the mood before drug intake. And to investigate those questions, we designed a study, a retrospective study, and pooled 10 double-blind, placebo-controlled and crossover studies. 9 of those studies had MDMA dose of 125 milligram, and one study had a dose of 75 milligram, which is a rather low dose, but within the scope of both recreational and therapeutic use. The 10 studies included 194 healthy subjects, and we decided to take 18 predictor variables, to which I will say a few things in just a bit. And the analysis was done with a multiple linear mixed effect model. And the results were corrected for multiple comparisons and also adjusted for MDMA dose per body weight. First, to get a little bit an overview of our study cohort. It was a rather young study cohort with a mean age of 25, and the age was ranging from 18 to 45, which also depicts our including criteria. The cohort is well balanced in terms of sex, so 50% were male and 50% were female. And it is, if we compare it to other MDMA cohorts, it is a rather naive cohort. So only 38% had illicit drug experience, and only 21 had taken MDMA before. Here to say maybe is this THC as cannabis is excluded from the illicit drug experience. Yeah, otherwise it would be like 90%. And most of the subjects received 125 milligrams. We captured the personality traits with the NEO-5 factor inventory, which includes 60 self-reference statements, such as sometimes I feel completely worthless, and you have answer options from strong disagreement to strong agreement. The NEO-FFI captures the big 5 personality traits, so like openness and neuroticism and so on. We also had an eye on anxiety trait, and we covered this with a state anxiety trait inventory, which consists of 20 statements describing the general anxiety. Yeah, here also like sometimes I worry too much about unimportant stuff. So next, the set, which is very important, as you probably know. We tried to get the set with an Adjective Mood Rating Scale. So this AMRS consisted of 60 adjectives on a 4-point Likert scale, and we tried to capture the mood just before the intake. A mood like a general well-being or the anxiety or depressiveness of a subject. We asked them to state their feeling, their current feeling, like are they feeling funny, not at all, a bit, pretty much, or strong before the intake. And to cover the genetics, we choose the only genetic factor that is established so far, or solid established so far, and it is the genetics for the enzyme cytochrome 2D6. So we see that poor metabolizers, so people who slowlier metabolized MDMA had a higher effect. For example, a higher systolic blood pressure or a higher any drug effect, or they like the drug more compared to intermediate and extensive metabolizers. So to the results, if we now put those predictors and response together, on the left side you see the predictor variables. Yeah, I will zoom in a bit. And on the x-axis you see the response variables, and when we now perform a nice correlation heat plot, we see this. I mean, yes, it is. It is quite a lot to process, but there are a few things I want to highlight. For example, the well-being predicted quite well the good drug effect and the liking of the drug. And on the other side, the neuroticism, the personality trait neuroticism, predicted the dread of ego dissolution, also sometimes referred as anxious ego dissolution. And the anxiety were pretty much predicted by the neuroticism. But the most dominant effect we see here is the MDMA plasma concentration, the dosage, and the body weight. So we decided to correct the whole figure with dose per body weight and condense it a little bit. So on the next slide we see the condensed. Here still the MDMA plasma concentration was predicting the any drug effect as well as the mean arterial pressure as most accurate. But you can argue MDMA plasma concentration is not really a predictor, right? Because you cannot measure it before the drug intake. However, the personal trait openness to experience seem to correlate with, for example, an empathogenic effect like the closeness, or also the oceanic boundlessness. And we saw in a few presentations on this conference that the oceanic boundlessness corresponds to an increased success in the psychotherapy. Also to mention the neuroticism and the trait anxiety. Subjects who scored high in neuroticism and trait anxiety had also an increased threat of ego dissolution, so they had more negative effects captured by the 5-dimensional Alter Scale States of Consciousness questionnaire. And the set, here negative mood set depicted by anxiety and depressiveness, and also introversion predicted the anxiety felt during the trip. So we take those things together, a lot of informations. The drug amount in the body is the most significant predictor. However, it is not really a predictor. But it predicts the vital parameters and the overall drug effect. The negative mood before intake can predict anxiety felt during the trip. And also personality traits, so character traits, neuroticism and trait anxiety predicted the negative effects during the trip. But openness to experience, so subjects who were open to the experience felt more positive effect from MDMA. So they felt more closeness, and also they felt this important oceanic boundlessness more. And they had a little bit more visuals, but I think they are just really, really open to the experience. Of course, as with every study, we have to keep some limitations in mind. So the setting was the same for all subjects. They were in a quite sterile room, and you can say setting is probably a predictor, right? We heard that from Jasmin Schmid 2 hours ago. The setting might be a predictor. Also, to the setting, I count the investigator, and of course, the investigator wasn't the same for all 194 subjects. And those were healthy subjects, so we need to be cautious when we translate the results to a psychotherapy setting. And it was, like I said, a retrospective study and thus observative. So a prospective study would be needed to check the results. Thank you very much for your attention.
Was 194 subjects single exposure or multiple exposures?
That's a good question. There were single exposures. Some of the studies were like interaction studies where we tested the interaction with another drug. So they received one time MDMA, one time another like bupropion, and in combination with MDMA. And so they received 2 times MDMA, but not, of course, not on a single day. So.
Are you aware of studies where the same subject would go through 5 or 10? 3 maybe sessions?
Oh,
and see if they different, if they rate differently on
So-
all the forms of the lesson?
So you mean the experience, like the experience is a predictor? Or
No,
is
but
that-
you have an experience and then you fill out your, what am I experiencing every hour. That's how you come up with your graphs.
Mm-hmm.
So if I am a subject and I have only one experience with you, and it's one time,
Yes,
then I give you this result. Another time it's going to be very different.
yes.
For me, even as the same subject. So do you have studies where the same people
Come
repeatedly
over and
do
over
the
again.
same thing?
No, they only received one time MDMA and only MDMA. So we didn't have like a dose response study or so with MDMA. So they only came once. It's good. Yes?
I have a question. Did you make also a collection of the new 5 regulatory after they took the MDMA? Because that's what I really thinking about, if there's a change.
Change, like with LSD, you mean? No, we did not. Unfortunately not. Just before.
I was once told by someone that did research that at a lower amount, the negative effects show up before the positive effects. Did you see that when you compared the 75 to the 125?
I did a study with the same cohort and looked into the safety pharmacology, and there we interestingly see that the bad drug effects were as pronounced in the low dose as in the high dose. But yeah, they come first. The anxiety comes like at the beginning, mostly at the beginning, because yeah, the MDMA, when the MDMA shows the effects, or
Not time-wise. What I understood was that you find that the 75 you find the difference between the good and the bad effects much more pronounced at the 75, where a lot of people have the bad effects and have less of the good effect than at the 125.
yes, that's true. That yeah,
Okay.
you see the same bad drug effects in the lower dose as in the higher dose, but you see less good drug effects in the lower dose. So yeah, it's.
I was asking myself, you said you gave 125 milligrams, right?
Yes.
And that was not weight nor sex adjusted.
Yes.
Why is that so? Because from my understanding, 100 kilo male on 125 should have a different response
Of course. Yes.
than a 50 kilo female.
Yeah, of course. This is because we gave a uniform study, drug. So we gave pills with a standardized amount of drug. As it is also done when MDMA should become a medicine, it probably will be like this. You get either 125 milligram or 100. So there could be an adjustment, and we also suggest in a previous study that we would give women 100 milligrams and male 125 milligrams. But here we choose to give everyone the same dose, as it is done with many studies, many phase 1 studies.
I understand that thing. I was just questioning
Why we are doing it.
sense that makes, given that there are differences which are not arbitrary.
Of course, this can be seen as a limitation. Yes.
I have one other question.
Yes, of course.
Okay. So just speculatory, right? While we are looking at anxiety scores and dread of ego dissolution being increased, and that probably not being a good thing, right? People probably do not like the substance more or the experience they're having more because they're having them. But it seems to be a variance which is existing in the population. Would it make sense to help these people with an additional compound to have maybe less of these side effects, which eventually could help them to have more of the experience of MDMA, which they actually can use in a therapeutic way?
So are you suggesting that we give them like amphetamine on top of MDMA or?
Anything which basically reduces, manipulates anxiety could be of use.
Yes, or are you benzodiazepines or substance like that, or just, of course we should reduce the effects, the negative effects, but what is the right instrument for this? I mean, benzodiazepines can reduce the effects, and yeah, you can't use that, but I think a proper, if you prepare your subjects properly, like, and you lead them as an investigator, I think you can minimize the negative effects. If you
We have time for one more question.
So question about the subjective ratings of experience.
yes.
The standard deviation, I assume that it's a standard deviation, but it seems really small, and I would assume that if you have a visual scale and you cross the market during the experience, and you have 100 people, and you ask questions about very subjective spiritual feelings, there should be more variation.
More, yeah.
Really small.
It is the SEMS, or the standard error of the mean, and I mean it's quite a large sample. It is. We saw the effects in 162 subjects, so the standard error of the mean gets really, really small.
That's
in
a
such.
deviation of the mean.
Yes,
Okay.
yes. That was so.
Thanks a lot, Patrick.